Poquito. Little.
Are you
I
trying to
know.
learn Spanish?
What is it? Yo helado. No, yo quiero el helado de chocolate. Woo! That I want chocolate ice cream.
Small group activities. And we can't do small group activities in that big room when we're turning around and we're trying to, we can't get it done.
I just feel like none of us are really like within this environment. Like it's not really conducive.
Well, we're not gonna address that right now. I know that was told to you the last class, but we need this kind of a setup in order to do small group activities, because when we're sitting in a row, it doesn't work out. Sit in your groups that you were assigned for this week. Okay?
I don't even know what my group is. Everywhere.
There's an empty chair in front of Mackenzie, and there's another one over there by Diana. Are we short of people?
All right.
Kenzie, where's our group at?
Hi, girl. Yeah, doing it. So sorry.
No, you're fine. Take your
I just
time.
get a little crazy. And you will need to get out your textbook, volume 2 textbook.
You can get it online.
Yeah, you can do that, or you can talk about you starting. I've already had questions about the room change. You can talk about that if you want.
Are you guys wanting to do the room change because it's more spacious or why?
I think that and the having to sit with your back to the wall,
Yeah.
that's the hard part. Is when you're on this side right here, and you guys are up there talking and showing PowerPoints, there's not another one back here, and so you have to sit the awkward direction, and that's my big
We
thing.
have to awkwardly anyway just have space to put our laptops in front of us and like all these single things, not so much.
And I know like you said, like the small groups, like it works better in here, but we kind of do some in the class as well.
Do you do the small groups in there and it still works to like sit in,
We just sit at the same table.
like in a row?
And some of us just kind of move too sometimes.
And then if we're in opposite and there's like two in front, two in back, we can still see both TVs from whatever side we're on.
I don't care if we do that, but we need to keep in the first section of the class, like move to the front. is there enough chairs in the bottom part for everybody to sit down low in the first floor? Of the first 3 rows?
I think we've done that.
I think the
Yeah.
first 3 rows get completely filled with us.
'Cause we did it before we moved here.
Okay. Well, Barb and I still have to teach in these 2 rooms, cause that big lecture hall is not available on the day that we teach, but I don't care if you guys wanna stay in that big lecture hall on Tuesdays, we can do that.
I do want them in the front couple rows
The
though.
front, everybody in the front
And sit in your groups for the week, cause that'll help you, then we don't have to move everybody around when it's time to do an activity.
I didn't even see him.
Okay, so this week we're still talking about the nursing process, learning objectives for this week. See creative approaches to problems utilizing the nursing process and clinical reasoning. Utilize nursing judgment and the nursing process to improve patient outcomes. So you guys had to do, for your pre-work, you had to look at, was it Tanner? The Tanner nursing process?
Yeah.
So, not the nursing process, the Tanner theory. So in your Think Like a Nurse book, I think there was like Gordon's, and I think we gave you a copy of Gordon's. There was Tanner, there were all kinds of different theories on your little groups that we've had. Those are different theories. So the nursing process is basically, each of those theorists has made their own idea from the nursing process. Am I saying that right? Kind of. The nursing process is,
Each nursing theorist has a picture in their brain of how people
the
think.
process.
And they've all put together their own interpretation of how people think. They're all similar, but they're not exactly the same. And the 2 that we want you to compare, that you were to compare this week, were the nursing process and Tanner's, okay? Those 2 theorists. Your book gave you a couple of others in addition to that. We're going to focus on Tanner and the nursing process. It also included at least 2 or 3 other ones.
So when we say the nursing process, we're talking about add 5. Okay, and then Tanner's was, I'm waiting for that, okay, we're implementing, noticing, interpreting.
You want those?
Oh,
I'll
I'm
go
just
to the
writing
end.
them up here.
Where we put those?
Responding, yeah. Responding.
And then reflecting.
And reflecting. Okay, so you can see where assessment, diagnosis, planning, implementing, eval. Okay, I just want you to keep those in your head, keep them, and so basically this Gordon's that we handed you, is another idea like this, except it has 11 parts, okay? But you need to be familiar with,
nursing process.
what?
That we told them to use in the nursing process.
Right. Okay. And then we passed out another nursing process sheet.
wanna do it anyway? So I'm just gonna take 15 minutes, probably I'll try to keep it 15 minutes. And I'm gonna go through this PowerPoint that we put together to help you look at the nursing process. It's really a big review of what we talked about last week and what you are going to be doing and probably have been doing in lab, okay, with nursing process. Then we're going to pull out a couple of case studies for you to listen to and create your own nursing process. And then we will wrap that up, okay, in a nice little package. And we'll do that in groups, all right? So I just want you to open maybe your textbook, because I want to point out to you some things about your textbook, all right? I really think that everyone needs to know
And if you have your
textbooks.
computer, you can split screen it, because we're gonna kind of go over a little bit on how to look
Use
through
it.
your textbook and use it. Actually, your computer, access works perfectly, because when it gives you that, module 36, you can click right on the numbers. I actually like it better, the way we have the readings split up, but I also want to point out that when we read for this chapter, we started in module 36. Do you have enough room there? Yeah, you need another,
There's an extension cord
Here.
at the bottom. If anybody needs an extension cord, I keep them on the bottom of this cart so you can plug them in.
There'll be space to plug in.
Yeah, that may be better.
Yeah.
I want you to look at the beginning of module 36. I don't care if you look online or if you look on the textbook itself. But the chapter that we assigned, 36A, is all part of 36. All right? We aren't going to assign you the whole chapter of 36. We're only assigning you 6 or 8 pages. Now, there's a whole long philosophy of why we're assigning you 6 or 8 pages. However, if you're having trouble understanding what we're talking about in module 36 in the nursing process, go to the beginning of 36 and start reading and looking at what we're talking about in chapter 36. Okay? We're not assigning you all that reading. But I'm going to point out to you some things in 36 that will help you to understand what we talked about today as we go through this PowerPoint. All right? You want to do it? You want to do it? Okay, so I'm going to talk about the nursing process starting on page 2494 in your textbook. And it's exemplar 36A. We didn't even assign all of exemplar 36A, but you should definitely read all of 36A. When you come to something you don't understand in 36A, I almost guarantee you it's before that in the explanation of chapter 36. We're not going to assign all that. You are supposed to be a self-directed learner. We don't care if you look in the textbook or if you Google that or where you look it up for a resource, but don't skip over it, okay? If you don't understand a word or you don't understand a phrase, you got to figure out how you're going to, what that means. And so you're going to have to dig deeper is what I'm saying, okay? So, going to give you a quick wrap-up of what we've done so far with nursing process. And it starts with 36A, all right? So, the nursing process is going to identify for you the status of your patient's health care, okay? This whole thing is about identifying what your patient needs. And it's going to help you to determine which nursing interventions you need to do as a nurse. And how to evaluate whether what you've done in these interventions has made an improvement in your patient's status or condition. Are you with me so far? That's what the whole ADPI means. Now, when we talk about patient, we could be talking about an individual who's laying in a bed. We could be talking about a family member who's taking care of that person. We could be talking about a caregiver different than the family member. We could be talking about a whole group of individuals. But who is the plan targeted at? Okay? A nursing process is always changing. So when you write a plan for your patient, an ADPI, okay, it's probably going to never be exactly the same. So if somebody comes in and looks at it in 3 hours or 3 days or 3 weeks, it's not going to be the same because it's constantly changing depending on what's happening with your patient, all right? It's dynamic, it's not static. It's always targeted at the patient, how the patient is going to respond. It's centered around the patient, not what's best for the nurse, not what's best for the insurance company. It's what's the best plan for the individual that we're writing it for. So we're going to organize it that way, by what we want that patient to achieve, all right? And we're going to do it with some specific goals and outcomes in mind, targeted at that individual. Always very holistic in the approach. When we start collecting data for our patient, we're going to include physical, spiritual, emotional well-being pieces, all right? That might be biological stuff, physiological stuff, psychosocial, socioeconomic, spirituality, whatever it is. We're going to look at the whole picture for this patient. What does this patient need to return to their absolute best potential health state? All right? Now notice I didn't say 100% healthy. I said, how are they going to get to that health state? The best one for them. So, it's a decision-making situation. Each step of the way, we have different decisions to make, but we're constantly making decisions about that plan of care. Now, we say that the nursing process is both interpersonal and collaborative. Interpersonal, what does that mean? That's a big word, interpersonal. Well, in this case, what we mean is that it's going to require patient accountability, and the patient's going to have to buy into this. They're going to have to cooperate with this plan of care in order for it to work for them. Now, some patients can do a lot to buy in and to be accountable. Some patients can't do anything hardly to be accountable. But what will the patient do? You got to get the patient's perspective. Because you can write wonderful care plans, but if your patient isn't bought in or can't do those things that you put in that plan, it's just scribbled on paper. And collaborative. Okay, what do we mean by collaborative? Well, that means that in that plan, we have taken into account the patient, the family members, the nursing staff, the healthcare providers, any other ancillary services like PT or OT or respiratory or any other outside resources that have to become part of this plan. It's collaborative. It's not just you and me and you and a patient, or me and a patient. Okay? It's collaborative. If we don't take into account the rest of the people that have to be part of that care team, we've missed it. Okay? Does that make sense? about add pi last week. That was the points that we used in the, on the paper that we handed you. We've made an adjustment to that paper this week and we handed that out. You want to talk about that then? Okay.
So last week, we didn't have,
That's the old one, I think. No, that's the new one.
we didn't have this ADPIE part at the top, right? It didn't say, assessment, diagnosis plan, and I think,
We think this will be easier for you to
it's
understand.
just to help you make that connection between that ADPI and the rest of the nursing process, where those fall into. So
But we
that's
still
the
made one
difference.
mistake.
that's the difference between the last one we gave you and this one. It's just helps you, tie those together. And then
This part.
this as manifested by
Doesn't
should
belong there.
actually be with the plan in this third.
It should be above outcomes. So cross it out under diagnosis as manifested by, or some people call it as evidenced by, I don't care what you call it, but it shouldn't be in that column. It should be under your short-term goal and before your outcomes. So, in your first column, you have assessment. That's where you're going to start collecting your data, your subjective and your objective data, and you're going to organize it that way. Under diagnosis, that's where you're going to formulate your diagnostic statement according to the current NANDA list that we showed you last week. The current one is on your Moodle site. You can find it on the computer. And it is not a medical diagnosis. Medical diagnoses are out of your scope of practice as a nurse. You can't do those things. As a nurse, you have a list of medical diagnoses that are underneath your scope of practice. Planning is where you're going to formulate your goals and your outcomes from the patient's perspective. So in other words, the patient will blah, 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 blah. Okay? Implementation is where the nurse interventions, what the nurse will do in order to help that patient meet the goals and outcomes. What is the nurse going to do? I don't care if you write the nurse will, but it might not always be the nurse. The nurse might be making sure that respiratory does it, or making sure that PT has been there. But it's interventions that the nurse can make sure occur in order to help the patient meet those goals and outcomes. Okay? And then the last one is the evaluation process, where we evaluate, and this is important, we evaluate the goals and outcomes that we did in the planning stages, not the implementation and not the diagnosis, but the planning stages, okay, to see how they work, or if we've met those goals. Yeah.
So the assessment, we're gonna collect data. We've already talked about subjective, what the subject says, right? What your patient says to you. Objective, what the nurse sees and or measures. Remember we have the example where you had to pick out the subjective and objective last week. And I think the nurse looked back in the chart, was that subjective or objective? Do you guys remember? Subjective, right? Because it was somebody else's and it was something, the previous nurse had told them, right? So collecting the data is a continuous process. You're always reevaluating. You're always keeping up new assessment data, lung sounds, I&O, things like that is a continuous process. Organize the data. So we connected a Gordon's, it's that form that we gave you, but there's a link that you can access that if you want to print it out again. Then you validate your data, you're always double checking to make sure that it's correct and complete. So we found a neat table that gives you a bunch of examples of validating the data. Cues versus inferences. So the cue would be dry skin and tinting versus the inference that you make, dehydration. And there's a nice table in there that kind of gives you some more examples of that.
The nursing diagnosis, you know, we talk about NANDA diagnosis, just in case you're curious sort and you want to know what NANDA stands for. North American Nursing Diagnosis Association. They're the big wigs that decide if that works or not. And they're constantly meeting together, and nurses from across the scope are meeting together to determine the best diagnosis labels, okay? And they must be current. I have a list of nursing diagnosis from when I was in nursing school, like a long time ago. This started in the early 70s, this organization and their lists. And every couple years they update them, okay? Only nursing diagnosis, they are all within the nursing scope of practice. That's why they are called nursing diagnosis as opposed to a medical diagnosis. A medical diagnosis is not in your scope of practice. So you can't say that someone has, you can't use those medical terms. You can't say they have pneumonia or they have RSV. You can't. You can't even use the name of a procedure. In other words, they have pain related to an appendectomy. Nope, because what's an appendectomy? It's a procedure, okay? Why are they having pain? They're not having it because of an appendectomy. What are they having pain from? Their surgical site, so tissue impairment, okay? So you can't use a procedure and you can't use a medical diagnosis in that ADPI situation, okay? And what does the diagnosis do? Well, it identifies what their most important problems are, or their risks for problems are, or it might actually determine what their strengths are by what their weaknesses are. So in other words, because they have this weakness here, we might be saying, oh, you know, they're doing really good with this. So we haven't really addressed how you would write an ADPI when you're just talking about risks instead of an actual diagnosis. We want to give you an example of that. We'll talk more about that later. But if your patient doesn't actually have a airway, what can we use for that? Maybe they have some kind of a risk for decreased, they have a risk for decreased oxygenation related to a swollen airway. Okay, the fact that they've got a, they've had an asthma attack maybe. Okay, so they have a risk for this. Do they actually have a swollen airway? No, they don't, because it's only a risk for. Okay, Why is it important to identify a risk for? What?
So we can prevent it.
Yeah, especially when it's airway, because when we talked about prioritization, what was number one? A, B, C. Risk for diagnosis. Maybe your patient's a risk for a fall or a risk for something else, but they don't really have the problem, but it's a big risk. Are you going to have signs and symptoms for a risk? No, because they don't have it. So you can't put in any subjective or objective data. So we'll treat that a little differently down the road, okay? But we always have actual diagnosis above risk for diagnosis when we're talking about priority. That's all I want to say about it right now, because I don't want to confuse you. That's not what we're doing right now. But it does address the fact that there's risk. And a risk is not an actual problem. It's a risk for that problem, all right? A risk for a problem is not as important as an actual problem.
So if you have a risk for diagnosis, nursing diagnosis, what do you think you're gonna use to
Under your assessment.
do your assessment? Like what comes to mind? How can you prove that they're at risk for that?
Say that again.
Previous medical records.
Oh, that's good. What would you see there? Like,
Past surgeries or complications that they've had in the past with the medications or something.
So previous history,
Yeah.
okay,
multiple comorbidities.
there's a lot of things that might be why you're concerned about that risk. They might be safety issues, they might be history issues, they might be cognitive issues, they might be a lot of different things.
When you're looking for a risk for, you're thinking of risk factors, right? What makes that patient at high risk for that problem? And you're talking about risk factors. So your risk factors are age,
How are you gonna put them in that form? Any ideas? Well, here's what I would do. I would go down to the bottom below objective data, and I would put the term risk for. You can only use risk for if your nursing diagnosis says risk for something. There are certain nursing diagnoses in that NANDA list that say risk for this, risk for that. If you choose one of those, you're not going to have subjective and objective data. You're only going to have risk for data. And you can put those risk for items under the heading of risk for. Okay? Most important point of that, two things. You aren't going to have subjective and objective data if your diagnosis is risk for. And number two, a risk for diagnosis is always a lesser priority than an actual diagnosis. So if you're asked to do the 3 top nursing diagnoses for your patient, and you give 2 risk fors, your patient better be dang healthy. Because an actual diagnosis is of higher priority than a risk for. Make sense? Yes, sir.
Could you use objective data if they're like a risk for a fall?
Like if they have poor balance, isn't that gonna be objective
What
data?
would they say to you in objective?
Well, what they say is gonna be subjective. But if me as a nurse, if I can evaluate, hey, you have poor balance, isn't that gonna be objective?
But if you see that,
If they have poor balance, let's say they have 4 of the things, are they at risk for falls anymore, or are they just probably they
waiting
fall?
for it to happen.
Are you talking about like maybe after surgery when they're dizzy, they might be dizzy?
Coming off
Or
or,
if they, the moment, risk for falls generally, is gonna be way down on the priority list because if you have a patient that's at risk for falls, they probably have a previous fall record.
Okay.
And so it's gonna be way down, like if any of you guys were in having surgery, that's gonna be way down on the list. Because you know your limitations, right? Your nurse can explain to you, don't get up without, you know, we're not talking about like a 90-year-old that may not know their limitations. And more important, nursing diagnosis would be like,
Cognitive impairment,
cognitive impairment related to not knowing limitations.
Okay.
Okay, so the
So yeah,
second-
you're concerned about falls, but that's not the diagnosis.
Okay.
Yeah, and so that's why it kind of pushes it down,
Gotcha.
just because, falls is kind of, it's kind of one of those things, once you fall one time, you probably shouldn't be using risk for, because they've got all kinds of other things going on that are more important that you need to take care of first before it's that risk for falls, if that makes sense, I don't.
Gotcha.
Whenever you look for a risk for, whenever you're considering a risk for diagnosis, consider if there's an actual diagnosis that's causing that risk for, and go to that instead.
Yeah.
That's always how I try to look at it.
So like instead of risk for fall, you could do impaired
Correct.
mobility or something.
Or impaired mobility, yeah.
Right,
So then, like, as a nurse, do the nurses decide, like, their risk fall factors? Like,
yes.
it's not a doctor like you need to find.
We do, like, there's that,
Like the bands.
yeah, and you do a scale, you do a fall scale.
Nurses do that assessment.
Yeah.
so then, like, okay, so
Obviously, if they have a history of falls, that physician is probably gonna order a fall risk.
yeah,
Like,
so,
if they came to the, hospital because they fell down at the nursing home 7 times, I mean, he's gonna transfer that without you even having to do your assessment. They're gonna be a fall risk.
The physician doesn't do all the thinking for you.
yeah,
The physician does write orders sometimes that would cover those, but as a nurse, you're responsible for that patient. So you need to think out of the box and
I
prevent
think
it.
what you guys, what's confusing about using that risk for is because even if somebody has a fall history, we still say they're at risk for falls. Does that make sense?
So,
But if
like,
we can't use that as our nursing diagnosis. I mean, that's just for us to communicate with each other that this person is at risk for falls.
so like, I was in the hospital this weekend, and I fell, so then,
Every time I go to the hospital now, are they gonna see that or will they take into consideration?
They're gonna take into consideration.
Okay.
I have a story about that, okay? My dad was in the hospital and he was talking to the nurses and he was talking about running his lawnmower and he got caught in, we live in Florida, right? And he got caught in the pond with his lawnmower. Well, he pulled the lawnmower out of the pond and fell, okay? So he's telling the nurse, she says, have you fallen recently? And he goes, well, yeah. He's 72, right? She's not assuming that my dad was out mowing the lawn and he got stuck and he was strong enough to pull his lawnmower out. That's not a fall risk, okay? So the nurse leaves the room and my mom goes, you told them you were a fall risk? And he's like, what do you mean? And she goes, now they're gonna put one of those stupid bands on you. She goes, I'm so embarrassed, because he didn't understand the nurse was asking him, like, do you fall down a lot, He was just saying, yeah, I fell, but he's not a fall risk. He's a healthy, mobile person, so you have to, the next time you go in, they're not, if you're busy again, maybe so, or if you don't know what's going on, you're cognitive impairment. But it won't stay, they won't automatically put a band on you.
can't go refer, like, activity intolerance due to, like, I mean, like, something you need to do, but like, something like that, or can it only apply to you?
It can be, activity intolerance,
That's just an example.
well, that kind of.
What is causing the activity intolerance? What is causing it?
Right, is it activity intolerance because they have a boot on their leg and it's rubbing, and so it makes them immobile?
Right, so we can
So
use it
it's
even though.
related to,
That would be a device.
assistive device, as evidenced by boot rubbing or whatever.
Okay, so even though it's under the cardiovascular
Yeah.
response is
But the
flat, it
majority-
doesn't have to.
The majority of the times that you have that diagnosis, it's gonna be, they can't breathe,
Right.
or they're hard, they can't keep up, right?
Okay.
So,
That's
that's,
it, no, 'cause-
and that, yes, it can fall into a different category,
okay,
but
so
you
like
have to.
fatigue, like it's under energy balance, like, I feel like that can be under different subcategories
Fatigue
too.
can be under pulmonary.
Exactly, so that's why I don't know if they're interchangeable within a
You've
category.
probably noticed by now that, there's only a specific number of nursing diagnoses, like not that many, right? But we can write that few number of nursing diagnoses to cover everything depending on how we write it. In other words, here's the problem, but what is causing that problem? That changes it. And that also begins to make it specific to your patient, which means that you're gonna have to pull out specific nursing interventions to make it fit. Does that make sense? It's a practice thing. Anybody here play an instrument? You weren't really good at it the first couple of weeks you did it, okay? It takes a while to practice these things and get them right. So we're trying to teach you a general set of rules about how to think about them. Because they're kind of about how to think like a nurse. And that's why we're pulling it out for you. Okay? We're trying to take that nurse thinking and put it into a graphic form for you, a picture. So we start with that nursing diagnosis, the label. So for example, what is the problem? Okay, well maybe our problem is fear. Fear. Okay, basic. So then the etiology, or the related to, okay, where does that fear come from? What is it related to? What is causing it? Well, we're going to say it's because they're unfamiliar with their environmental or their surroundings. Okay? Somebody else might have fear related to something else. All right? But we're going to say this one's unfamiliarity with their environmental experience. You can write that however you want, as long as you do not say it's a procedure or a medical diagnosis. Cannot use those two things there. Then, as evidenced by or whatever, what does it look like when you assess it? What are the components of your assessment? Well, the patient says they're afraid, or you see increased perspiration, you might see an increased heart rate, you might see increased blood pressure, they might be shaking, they may state that they may have whatever it is you can measure, or their increased respiration rate. You know, you can write those things down, you can measure those things. That's the data that you're collecting. Want to do it?
So planning, using the assessment data and the nursing diagnosis, and then you're formulating the goal and the outcome for the patient. So, I don't know what to tell you.
Well,
Nursing intervention.
the interventions are what you use to help that patient reach those goals that you wrote, that you write. It drives the intervention. What, because your patient is gonna do this and this and this and this, we're gonna use that data to create our interventions in the next section of the plan. We always start this with the patient will. So, goals can be short-term goals and long-term goals. We always ask for one of each. Our short-term goal might be, we're gonna help that client identify some behaviors that help in reducing their fear, okay? The patient will be able to state 3 goals of 3 things that they will do to help when they start to feel fearful. And they're gonna do that by the end of the shift or the end of the week. It's a short term, okay? Whereas a long-term goal, we might say something like the patient will incorporate 3 coping behaviors that reduce their personal fears by the end of the month, or by the next time they return to the clinic, or whatever your longer time frame might be, okay? So, observable patient responses, they're always observable. We have to be able to see what the patient is doing or hear what the patient says. We have to be able to observe what the patient is doing to help. These are always specific for the patient, and they're going to become what we use for our patient outcomes. And that's where we get the SMART goals. We talked about SMART goals last week. Specific, single action. Be careful not to put 2 or 3 things into each outcome or each goal. Because if you put 2 things in there and you get to the evaluation, what if they met one of them and not the other? Only one specific goal. Just write another one. So measurable, attainable, relevant, and time limited. And what's the patient going to do? Then the implementation, the interventions are what the nurse is going to do. Make sure it's within their scope of practice. There's all kinds of interventions.
We'll also post this.
Yeah, I'm going to put this on your Moodle site.
This.
Okay, so you can use this. Okay. And then the evaluation, we're going to talk about ongoing activity. So they might have met some of the goals, they didn't meet other goals. We got to change our plan a little. We don't have to change it all. I mean, some of the goals they met, we don't want those anymore. They met those, great. But if there's some that are ongoing, we're going to have to do some adjustments at that point. Any questions about that? Yes, sir.
So you said that some of the goals we have to be able to see that the patient is doing them and helping?
It's what the patient will do.
Yes.
Okay.
When it's a situation where if we work at a clinic and we say by the next time you come back.
Are there going to be times where some of this is a little foggy?
Oh yeah, you're going to write, it's how you write it.
I'm not going to go to their house.
And ways you can have them do that is create a diary,
Okay.
like blood pressure diary.
Like at some point, are we just going to have
Somebody-
to take their word for it?
Yes.
Okay.
Yes.
Because like
And-
when they're in a hospital setting, I get that we can measure what's
you're
happening
gonna
day
have-
Oh,
in,
but
day out.
sometimes they do after dismissal for their long-term goal. How are you
You're
going to measure
gonna have
that?
people that are successful with their diaries, that they're supposed to be, tracking their blood pressure 2 or 3 times a day. Are they gonna come in with, 70 pages of blood pressures, or are they gonna come in with 5 the last week before they came to the office, right? Because they forgot in between, and they might have done a week after and the week before. They're not gonna be, everybody's not gonna be perfect with their, yeah, or a food diary, or, I have a friend at Jacob's football game last night said her mom lost 60 pounds because she just got diagnosed with diabetes. Now, did she need to do that like probably 30 years ago? Yes, because she was on oxygen, she was like not able to get out of her home, and she was sitting at that football game with no oxygen on, lost 60 pounds since she was diagnosed, and I think it had been
Lots of insulin.
I think it had been 2 months. So you're gonna have successes, and you're gonna have people who don't listen to you. But you just have to try to find a way to motivate them, because the next time they come in, you have to kind of be the hard person to say, oh man, it looks like you kind of forgot about this. How can we help you remember? How can we help you do a few more blood pressures next time, or keep your food diary, or
In nursing
whatever.
school, we're all gonna look at your nursing diagnosis, we're gonna critique them, we're gonna put red marks all over them, we're gonna write stuff on them. We're gonna do that to help you get better at writing them, but when you go out in the real world, nobody does that, okay? But if you don't have a good plan, it doesn't work for your patient. So the better you get at writing them, the better you are at helping your patient improve their health. So that's the goal. And it is all about how you write it. It's all about how you write it.
Well, and you can only control the information you're giving them. You can't control whether they're gonna follow through with it or not. I mean,
I just didn't know if that would affect what is considered measurable, if it's something we can't directly be there to.
it does, but
Does
you're
it make
gonna
it
find
less
a
of a
way.
SMART goal was my main question, I guess.
No,
Okay.
it's still a SMART goal, because you're gonna say, okay, patient will record blood pressure blood pressures 2 times a day, patient will record blood sugars 2 times a day, whichever, and they're gonna bring them back into you.
Okay.
And you're gonna be able to measure that with, and blood sugar, you can print it out, and if they've only checked it 4 times since they've left the office, I mean, that's what you got. But what's important is you have to redirect that and say, what's gonna help you keep on track this time? Maybe, you just have to find a way, especially in the clinic where you have to be the one that's kind of spending that time to figure out what's gonna motivate them. So, like, if someone's not eating, if they're still eating ice cream with chocolate milk every night and their blood sugar is 500, that's probably not something that you can talk to them about, and then do that once a week, like, maybe, and then maybe they realize they feel pretty good if their blood sugar is not 500, so.
They might feel crappy though if they're used to having it 500 and now it's 150 or 100, because that's where it belongs, but they're used to it way up here, so they feel really sick.
Yeah. Okay, so let's take a little bit of a break. You guys need a break to walk around, and then we're gonna listen to 2
Case studies,
and then you're gonna have a chance to write some
nursing process.
nursing processes.
I want to
Just
say
more
one more
practice.
thing before you take off. We use 36A to teach you about this process. In 36B, which you will never be assigned for a long time, but there are tons of examples of how this looks once you write it out. So just like the tables and stuff in 36B will be of value to you, especially if you're a visual person. Okay?
Tons of
This is a
examples.
fabulous book. Use it. Just because it isn't assigned doesn't mean it's not a good thing.
I have a question. So you're in the hospital, take a patient who's like on a vent, where they can't say something to you. Then how would you go about your subjective on that? Do you know what I'm saying?
You
Like,
can't really do subjective if they can't. If they're awake, like sometimes when they're on the vent, you put them into like sedation, under sedation, so they're not struggling with the vent.
right.
But you're not always gonna have subjective. You could say,
So like, if they're like, maybe like visits to you or something, you could.
right, patient greets nurse by hand waving.
Okay, okay.
When nurse, you could say to them, if they totally understand you, you could say, squeeze my hand once for no and twice for yes. You could create a system, and then when you document that, you say, patient was asked if they were having pain, and they squeezed my hand once, and you explain your,
Okay.
you explain your, how you deduced to that, and then you'd say squeezed once or no.
Sorry,
What was that?
that was the beginning of that, I was trying to pull up
okay.
that video.
So you can do somehow, but a lot of times you might not have that. Like you might just have objective data, and that's fine. It depends on
Well, I know, because I'm just thinking of my dad, before he passed away, he was on a bench, and he used to, kind of like wave at us, but they gave us a board, like a whiteboard, and he at one point was able
to write stuff.
through that kind of stuff, so if you had to
You could do that.
do like a whiteboard or something
Yeah.
like that.
But you also don't have to, you could just say, patient writhing, patient grimacing. I mean, that tells you just as much as if patient said they were in pain, right? So if you're describing it with enough,
But what you're seeing is cues. Those are
right,
cues. They're reading, or they're sighing, or they're
or they're
grimacing.
grimacing when, let's say somebody had pain in their foot, grimacing when nurse touches foot. I mean,
You might
that
not have a whole
causes,
bunch of subjects, you might just have objects.
that causes pain, right? That hurts if they're like, or whatever is going on. So, you don't have to make it so that it's subjective.
Okay.
You can have all objective and that's still fine.
Okay.
Like, because there might be, what if it's a baby?
Right.
I mean, you're never gonna have that subjective.
Right.
Unless,
Okay.
I mean, no, because mom telling you is still objective. What the mom is noticing from her baby, and then she's telling you that she's still also doing the same thing you're doing, right? I think they're in pain, or,
Right.
pulling their legs up because their tummy hurts. Well, we're just assuming that's why they're pulling their legs up,
That makes sense.
So you don't have to have it all the time.
Okay. So there might be situations where you're gonna base it more off of your objective stuff, and that's how you'll,
Yeah.
next step.
Objective data is always
Yeah, we're going
more,
to two bathrooms and one.
substantive,
And one.
because you've got measurements that you can use.
Right, okay.
You can actually document that.
If you're gonna document objective data, you have to say patient states. That's not proof. They might be lying. The patient's playing on their Xbox and you say, what's your pain level? And they say 12 out of 10. Patient states,
And here's what I'd write.
patient states pain is 12 out of 10 while playing on Xbox.
So then it shows that, yeah, they're.
No distress noted.
Right.
He's a lying little piece.
Yeah,
okay?
right. Okay.
Give me some more narcotics. Just saying.
Or they come in and they'll tell you that they feel horrible and you check their blood pressure. Like, I have the most pain I've ever had in my entire life and they're breathing completely fine and their blood pressure is beautiful and their pulse is not racing and there's nothing.
Exactly, no signs. Oh, and the next sentence will be, I'm allergic to this, and they're all the non-narcotic pain medications. So, translation, patient states they are allergic to blah, 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 blah. All the non-narcotics. And rates pain at 15 out of 10.
Right.
Here's your blood pressure, here's your pulse, here's your respiration rate. There's no signs and symptoms except what the patient states. All you did was document the facts. You didn't say they were a liar. You just documented the facts. That's the doctor's job, to interpret what you recorded. He gets paid way more than you do.
But I have a question. I've seen doctors still prescribe prescription medication, like, oxyhydro and all of that, to a patient with a history of known for abusing these substances.
I know, but they're in between the rock and the hard place too, because what the patient states, They're kind of hooked on that.
Because exactly what you just said is what I've seen this patient do. And the doctor knows for a fact, and even family is requested, and every other doctor has
Not your
seen.
problem. Your problem is to document what you see and what you measure and monitor that patient. And when they get that pain medicine from the doctor and their respiration rate goes down to an 8, you should probably document that too and turn off their narcotics. But you don't have to make the call. You just have to document what you see. But if you don't document and stuff goes the other way, you're screwed.
Who said my name?
Me. Come here, I want to just picture that.
For this next part, you're gonna need to be in your groups, and you're gonna need a piece of scratch paper, all of you, because I'm gonna play a clip. And you have to listen to the clip, because the reason I'm not gonna show you anything or a list, I'm going to let you listen to the clip, because I want you to listen to the patient and collect the data the patient gives you, okay? I know you're not going to have a lot of subjective stuff, but you're going to collect subjective and objective data, and then you're going to come up with a nursing diagnosis. This will be in your group, okay? But you all listen, because some of you will get stuff and some of you won't. Within your group, come up with a nursing diagnosis, write SMART goals and outcomes, one short-term, one long-term, get maybe 3 outcomes and then 3 interventions and some evaluations. When would you do that evaluation? And when would you do that evaluation? Okay? Okay? This is going to be practice. Then we'll kind of share what we've got. I've got 2 of these I want you to listen to. They're pretty short.
Mary Lou. Oh, wow. I've been here in this rehab unit for about 4 days now, and it feels like I'm never going to get out of here. I will say I am seeing a little improvement. When I first started with physical therapy, they just wanted me to sit in a chair. I was so unbalanced that they had to use special supports so I could sit straight in the chair. Otherwise, I would just fall right over. Gosh, I'm only 20 years old. I wonder how this could have happened to me. I'm healthy, I eat well, and I exercise. Thank goodness, at least I can think and speak. But I can't do anything for myself. I can't even sit up on my own. I want to finish college, but how will I get around to go to classes? My poor husband. We were just married 6 months ago, and now he's going to have to take care of me. Gosh, the left leg and arm are so useless. They can't do anything. I think the doctors and nurses think I'm a little bit nutsy. They had a psychologist come and talk with me. He was a nice guy. He was asking me why I called my left arm and leg the arm and the leg. I feel like they aren't really mine anymore. They are useless. The nurses have been coming in and they try to be encouraging. They're always telling me that it's time to go to PT and OT. It's so hard to do all of those exercises because I can't even believe this has happened to me. My family has been worried and they're coming in as frequently as they can. My husband has been great and has been trying to encourage me. I'm usually a pretty positive person, but I'm really afraid about how this is all gonna turn out. Will I ever be able to work? How about having kids? I'm angry at God for allowing this to happen to me. I wish I could get to church. Maybe if I was able to get there, it would help me feel better.
together in your group and see what you can do. And I'm only gonna give you about 10 minutes for that, and then we'll share some of the things that we came up with. You're probably not all gonna come up with the same nursing diagnosis, that's fine. But make sure they're a real nursing diagnosis, so you're gonna need your NANDA list.
So we have impaired physical mobility, impaired sitting. She could be could be caregiver role trained for her husband that I take care of. Could be risk since she was probably still in care by the way how it sounds that everyone came to visit her. I think a lot of it is coping responses. Powerless. She's, from what she stated, you know, I'm angry. I'm afraid, can't work, my left and right, saying the leg on from the psychologist. She has everyone encouraging her, but she doesn't feel like she can do anything because her left arm and left leg, so sounds like paralysis, some kind of sort of injury.
Is it powerless or hopelessness?
I have powerless on my list.
Oh, okay. I just hadn't scrolled past it.
Spiritual distress because, you know, I want to get to church. I'm angry at God.
Could we incorporate that with hopelessness though?
That could be one of our goals. Kind of like a fine line between all of them. Just depends which way you want to go.
Some ideas, I just
So which one do you guys want to go with?
things that I remember from,
I like powerless.
like, just start
Oh,
thinking
okay.
back to what she was talking
Found it.
about, if you're having a difficult time deciding.
We put like patient needs.
Powerlessness
Yes.
related to
When she said, I don't know what's gonna happen. Will I have kids?
impaired mobility or ineffective mobility? Because it's not really encouraged to move at all.
The nurses
On one side.
encourage.
Yeah, but
Okay.
By specific domain.
I wrote down that she was in denial, like, she does, she doesn't even think that, like, she's thinking about she'll never. Yeah, she's like, will I ever be able to kid, will I ever work,
Angry with dogs.
Objective.
Source. Objective. Suicide.
So projectively we can put she's in the rehab unit, she stated, I'm never gonna get out.
So they like put in here.
So that's a statement.
I mean, we couldn't see that.
Yeah, Yep. What do you see?
Okay, that'll
Yep,
help me.
put yourself in the situation.
So maybe we could put,
You're not gonna see, you're gonna not necessarily have the same priority list as I might have. Because I might think that certain things are higher on my list than you might think. And when you get past A, B, C,
She's
the
talking
other
about,
things, they're kind of subjective. And this minute is different from that minute.
she almost seems ashamed, about
Yeah.
her disability.
Exactly.
okay.
Like, how can I put this on my husband after 6 months?
Or eye contact.
And then she's doubting her ability to go to college, work, have kids. She stated all this. So she's having to doubt her performance previous activities before accident. She could go to work, go to college, and have kids at that time. Now she thinks she can't. Independency, objective.
But what does that mean? Because we have.
And yeah, she did a lot of times. I don't know, what do you call that sign? She was kind of like, yeah.
On their paper it's related to, or in their book it calls it the etiology.
Would objective just be like PT working with her?
Dependency and inadequate participation in care. So it would be,
Size, yeah.
she has to use those devices.
She's not really, she doesn't really look forward to the future. She's fearful.
It goes here. Just cross it out. So what's her? Well, you could say as manifest.
And can for inadequate participation in care.
Is she really inadequately participating? She just feels like she's not making it.
She feels like she's not, like it's not helping. Like the nurses try to encourage her, but it's no help. Like she doesn't feel like she can do it. So she's not in full participation of it.
As long as you know what it is.
Okay, so she's different goals. Did they guys ever give you the missing diagnosis book?
Not a book, but they sent out a list.
Not the list, the actual book that gives you the rationale to it, the goals, nursing assessments. No wonder you guys are struggling. I'll email it to you guys. Because this book gives you everything.
Goals, we could do like maybe sit in a counseling session or a support group or something once a week or daily with spiritual advisor while you're in the rehab unit. Since she's angry with God.
Yeah, that's what I was thinking we should have.
I don't know if daily would be too much though. Although she's not really doing anything else.
This is what I'm talking about.
It's all the nursing manuals in their definitions along with the rationales to it, along with what short-term goals, long-term goals, nursing interventions, evidence-based by, and what family can do after discharge.
Denial.
Alright, so which one, what are we thinking? Weekly meetings, every other day meetings.
Yeah, but you have to think, she's not in that mindset. She might not want to go to every other day meeting.
Well, she said that she could go. If she could go.
Oh, yeah,
She did say how angry she was, but if she could go, it matters.
If she
smoke those readings every night, let me tell you.
Our nursing diagnosis? Yeah.
Too many times I have people be like, what is that?
That's Tanya.
Or when they play that song.
Oh my, yeah. The first time I heard that dance for babies, and I thought it was like,
Hopelessness, and then I think it's next is related.
oh my god, that's so terrible. And someone's like, what are you talking about? I'm like, no, just not even like a baby was just born. I'm like, oh.
Psychological history of the family.
Someone died.
I thought it was like an remembrance thing.
Prolonged active
Which is,
And it's like really long. It's creepy, especially in the middle of the night. Yeah, extremely creepy.
which is good that I figured that out, because then I would wanted it for two, because there was twins, I would have been like, we're just getting rid of everybody.
So what are you putting for the short-term goal?
Like bi-daily meetings with chaplain while in rehab. Or should we just put like until this
Point of start crying.
My problem happened
Only 20, just medical. I know, I was thinking, oh my gosh.
Because then it's not every day, but it's frequent enough that if she needs a break, she can have a break.
Yeah.
we have to just describe what we want.
True. Also true.
Related to.
Long term.
Now we need our outcomes, right?
Right. She said she was making a little improvement, but not.
We need our short-term goals, right?
Not effective.
The next scenario for you, and this is the husband, okay, so it might help you develop some things on your interventions, or, but we're also thinking, we want you to develop a nursing diagnosis for the husband as well, okay, so be thinking about things that he's telling you in relation to her and in relation to himself, okay?
When we open up this PowerPoint, if you click the hyperlink on here, you can find them. Yes?
Maybe like an hour before class or something, post the.
No.
Okay, cause she does that in, easier so we can take notes on the PowerPoint.
We want her to go to
But
build
it
the
okay,
strength, and
you
by
can do that.
build the strength, she will able.
We were told not to. We're all supposed to not be open.
Yeah, they're not being delivered, yes.
So,
I'm Rob.
Are you ready?
Are we gonna go over the first one yet, or no?
If
This is
Mary Lou
second one.
stroked to find her on the floor
Take note.
and unconscious, I was dumbfounded. I tried to get her to wake up. Although she could talk to me, she didn't know what happened or how long she had been on the floor. I called 911 and an ambulance rushed her to the emergency room. At first, they weren't sure what was going on. But after the doctor saw her and looked at the tests he ordered, they said she had a clot, and that's what caused the stroke. Since she had the stroke, Mary Lou has been working hard, doing all the exercises and therapy. I was a mess at first, but my father suggested that I go back to my normal activities because fretting and worrying wasn't going to help Mary Lou get better. So I've been back to work, but I visit her every evening. She's making some physical progress, but seems to get upset about things easily, which isn't really like her. But I can imagine how upsetting it must be for her. Her whole life has changed. I haven't pushed her to talk about it. I guess she will when she's ready. They tell me, even though she just had the stroke a week or so ago, that she'll be coming home in a few weeks in a wheelchair. And they hope to have her walking with a cane. by then. I'm going to have to learn how to take care of her. I'll have to come in for training sessions. How much will she be able to do for herself? Will she be safe if she's home alone? It all seems kind of scary. I never thought our lives would be like this, but I have to do all that I can for her. I love her, and I want to take care of her.
Okay. So go to your list and start thinking about the data that you collected. Who's this patient going to be? The husband, right? It's not the lady in the bed or the wheelchair. It's the husband that you're going to be writing this plan for, okay? Think about the data you collected and go to your nursing diagnosis. Look for those that are most appropriate.
He was concerned, right? So his probably are gonna be some psychosocial things.
Caregiver role.
I'm putting it down for disabled family and coping.
Caregiver role.
Yeah, that's a good one. How come? Then you put that in. There might be a lot of reasons.
Let me go to that page. So I think a short-term goal, we should do something about setting goals consistent with optimism, meaning life and belief in self and others.
Fear.
Fear, anxiety.
Worried about costs. Worried about how much she's gonna be able to do. Worried about safety concerns. I don't know if that really be fear.
Which one?
but
Maybe we'll set one
maybe
achievable
anxiety.
goal every week. For her or for
Uh,
maybe that's a good short-term goal to think about.
Anxiety related to
Wife coming home, wheelchair, cane, training. Will she be safe?
is that what we put there? Like, or do we like?
Oh, sorry, I was just trying, I
No,
thought you were
no,
trying
no.
to figure
No,
out
I
who's
always
inside.
think like, cause like, is the whole thing
That's
the diagnosis or just the part?
That's
First of all, whatever the,
Before the
Amanda,
related to?
yes, Amanda, like, so if you're going to
So you can
anxiety,
essentially put anything.
States I can
the reason why
or
is like,
express I
okay,
can
wife is coming home.
do something.
She has a wheel, some people are scared of wheelchairs, whether it's theirs or
Interact.
someone
It's
else's.
specific, it's measurable, make sure you have it timed.
You know,
You know what I'm
But
you
you
can
gotta
have
be
anxiety because there's no
one
communication
thing,
between them. They're not
time,
talking about what
measurable,
happened, they're just
specific. Or when you get
dealing.
the evaluation, you can't
Right.
evaluate
So
it.
you can pretty much put anything for the relationship.
So maybe we'll put like
Because maybe they only did
Anxiety.
2, and you said 3. Nope, they didn't meet the goal.
Anxiety related to, I'm trying to figure out how to word it.
Yeah, so anxiety related to what do you
Comment.
think?
Today.
Yeah.
I think her
You know what
coming
I'm
home.
saying? Like she'll say
Maybe
one thing I
his
can.
role as caregiver because she's coming home.
Yeah, related to caregiver role, as evidenced by stating these things. Yeah,
Each day?
that's a good one.
Each shift. Because I think if you give her a day,
I think it
I couldn't.
As long as you give
Like
it
I got
time.
married a month
Right,
ago.
you're good.
If I would have just
And it's
like,
reasonable.
oh, you have to take care of this person, I'd be like,
Oh, congratulations.
so that's
No.
our
You
short
can't
term.
talk because you're stroking, you write patient will save.
Just saying.
not quite that far. Some days maybe.
Caregiver role,
So,
strength. Right. Are we moving on to him or are we still doing? I don't know like the time frame like the other stuff. He's not like what if right now she can't sit like in that chair? What if that is her loss?
Yeah, but he's not coping
Like
quite
sitting in
I
that
think
chair
he's,
without support.
he's got like a lot of questions. Like he's not,
Yeah, like
he
patient
knows what's
will,
going on, but I don't think he's understanding the
sit in a
findings
chair.
of it. Like,
want, you know what I'm saying, like long-term time.
So she is going home, right? Like
as evidenced by.
Hopefully by the time she goes home, she'll be walking through it.
Is she gonna be safe on her own?
Yeah. Are you putting that under a subjective or objective? Or what are you putting that under?
Subjective.
Oh, okay, sorry. I hate this.
Is she safe on her own? PT. Said she would be coming home in a wheelchair.
Yeah. Yeah, wants to know how to
We could put like patient will sit upright, sit upright.
So then this is ours taken.
In chair.
How, what are we gonna do?
For a certain amount of time before discharge. Can we do that? So we'll like have the patient there for a certain time before discharge. So that she can
So
show.
then, objective.
My list is like, I can do it right here, list of goals.
Without support, right? Without support.
And then
So that was our long term.
we can see, not see, but we can hear the stress in his voice. Like, she's gonna come home in a week. She's gonna be in a wheelchair, and then maybe walk with a cane by the time she's discharged. You know, he's having.
What's the next thing? Oh, our interventions. This is where the nurse will. So nurse will use positive reinforcement. Say what? Nurse will use positive reinforcement. So like, you know what I'm saying? Like when she gets a little negative.
We can short term.
So nurse will use positive reinforcement.
He will seek counseling once a week because he needs to cope with what's happening. I think he's just in that like, oh shit, it just happened stage. Like, hasn't quite come to a realization like she had a stroke.
He's in a mix of that and like, what do I do?
He's dazed. There's the word. He's dazed right now. So he probably needs to go seek some therapy since he can't talk to his wife quite yet.
True.
Talk
He
to
says
someone that's in neutral.
he's not pushing her to talk about it. Or maybe even just talking to her about it. Like, what are you gonna need? Like,
Yeah, but if I
I
was
mean, if
him,
she's not ready to talk about it, that's not gonna work.
I wouldn't want to talk to her if she's getting angry easily
True.
and she doesn't have a history of anger. I wouldn't want to talk to her because then that could like delay the progress of her whatever she's made so far. So that's why I'm
Sit with patient. You know, like, how do we do that? Like, nurse.
Until
Okay,
what was
let's
discharge?
just jump in now and see what you've got. What kind of nursing diagnosis did you come up with for Mary Lou? Tell me what you had.
What?
Hopelessness.
Long term to
Anybody
be
have
like, get
anything
house ready
different?
for a wife in order to care for her. We could get him in touch with
Ooh,
home
good.
health services.
patient will feel comfortable by the time of discharge of wife
What is it?
to perform all cares for her, all ODIs.
Identity. Impaired mobility. What else? I just want to know what your diagnosis is right now.
Powerless.
Anything else? Powerlessness, hopelessness, disturbed personal identity, impaired physical mobility. Okay? What did you come up with for raw?
Caregiver role strain.
What else?
Anxiety.
Okay, what else? Anything else? Powerlessness? Yeah, he's pretty powerless.
Would disabled family coping be one?
What?
Disabled family coping?
Possibly. Anything else?
Complicated grieving?
What was it?
Complicated grieving? For
Grieving?
grieving.
Grieving, oh. What is he grieving?
His old life, before the blood clot, before the stroke.
Whatever it was that caused it? Okay. Could be. Anything else?
Stress overload.
Anybody have any others? How can it be all those things? Okay. Let's talk about the related to. Hopelessness related to what? Was that a nursing diagnosis?
Yes.
So why don't you just call that situational low self-esteem? Why does she have that? Related to what? What is cause for hopelessness? Can't use her arm and leg. Left? Very important. Be specific. What else causes hopelessness?
Lack of independence.
Is that a nursing diagnosis?
Diagnosis.
Okay, what else?
Stress.
Is that a nursing diagnosis?
Oh, paradoxical.
It's not really chronic in this case.
Heard something. Heard physical.
It's situational, and it might become chronic depending on how she rehabs. Right now, it's a new thing. She thinks she's been there forever, but she's only been there 4 days. If she's been there for 4 years, that's becoming chronic. At what point does acute become chronic?
6 months.
Has she become chronic? Nope. So she's not chronic. She could become that way, we don't know. Maybe she's a risk for that. But not now, she's not chronic. She's acute. What else is wrong with her?
Reset related to dependence on equipment and lost belief.
Dependence on equipment? Oh, you guys are testing my spelling. What else?
Patient stated how she's gonna work, go to college, have kids.
Loss of what though, did you say?
Belief.
Belief? Or you could say hope too. Okay, and then the other ones, you said what else?
She stated like, how am I gonna go to work, college?
Now, how can we wrap that up?
Also goals.
Autonomy, maybe? What's autonomy? You're in charge. People who are institutionalized, if it's prison or if it's hospital or whatever it is, for a while, they don't make any decisions on their own. And you lose that anything for 3 months. I couldn't think for myself at all when I got out of there. No, I never made any decisions at all. And I talked to someone shortly after that about who had been in prison, and he'd been in prison for like a year. He goes, oh yeah, you don't make any decisions for your other self. You lose that ability. You don't make any decisions. Loss of autonomy.
That's why a lot of times when you see like criminals over in credit card once they get out because they won't provide.
Exactly, they can't make decisions on their own, good or bad. Okay? All kinds of things that might cause hopelessness, disturbed personal identity. Do you have any others that we don't have up here? You all have the same signs and symptoms and the same data to work with. And look how many different ways you interpreted it. It's not necessarily this. It's how you relate it. And then because of this, the patient will what? Well, what did you say they were going to do for goals and outcomes? Well, just throw some stuff out. I'm not going to write it all.
There'll be 3 positive things by the end of the shift.
3 possible what?
3 positive.
Oh, 3 positive things. Patient will state 3 positive things. It's a nice day out. I didn't cry today. I didn't spill my eggs this morning. Whatever it might be, 3 positive things. That's a lot when you're hopeless. And you can measure that, right? You could get down to the evaluation and say, they only said 2 positive things today. They did not meet that goal. We're going to continue that goal. Or you might say, yep, they did it. They said 4 positive things today. Okay? You can measure that. What's the nurse going to do to encourage 3 positive things today? What is the nurse going to do? Nurse will give examples. What else?
You said that they would contact pastoral care, so she would.
She did want pastoral care. Nurse will contact pastoral care. Nurse will monitor patient statements. Nurse will document patient statements. Those are activities. Nurse will model positive behavior. Okay? What can the nurse do? Maybe there's other things, but anybody else have anything else that they included with this? Do you see how you can use a number of these to fit the situation, but it's all about how you write it up. Your plan for how to go about doing it. You do this all the time in your daily life. You just don't write it on a piece of paper. I've got to pay my electric bill by 10 o'clock tonight. How am I going to do this? Well, I'm going to go beg my mom for some money, or whatever it might be. Understand? What? I'm going to rob the bank, okay? Bad idea. You do this all the time. You just don't write it down that way, all right? Just saying. Okay? All right, let's talk about, you go ahead and talk about Rob.
Okay, so caregiver role strain. Who had related to for that?
We had related to weight needing significant home care needs.
I know that, okay, so these are written in proper sequence this direction, but I don't want to stand over here, so just so you know that when you're writing a sentence, it goes related to this way, okay? Okay. Related evidenced by?
Left side of weakness.
He doesn't have that.
Left,
Wife has.
wife's left side?
Well, yeah, wife's left side of weakness.
You could even have the wife's home care needs.
Powerlessness, did anybody have something different for that? Related to?
Ooh, that's a good one.
Low knowledge of use, what is new responsibilities? Yeah. Low knowledge.
There's actually a nursing diagnosis called lack of knowledge, right? Anybody see that one?
Yeah.
Isn't there's actually a nursing diagnosis that says lack of knowledge. In other words, you don't understand what's going on with you.
As evidenced by states. What did you guys use as your evidence? Who put this in?
We didn't actually utilize, states, he's a mess, I guess.
So states, did he say he was
Yeah,
scared?
Yeah, he said that, I'm a mess.
Scared? Oh, he said I'm a mess?
Okay.
I'm a mess. There you go. Okay, I'm putting an exclamation point. Okay, disabled family coping. Anybody have related to for that? Could you say blank stroke?
You can't say
You
stroke.
can say trauma, you can say, cerebral trauma, brain trauma.
Change in healthcare needs, whatever it might be, you can't say stroke. That's the diagnosis.
So you could say, change, oh, sorry. Change in life status or like care status, I guess. Okay. As evidenced by obviously needing more assistance. Okay. Complicated grieving, related to what? Wife's trauma.
You could use that for both of them. She was grieving too. What was she grieving? Loss of independence, what else?
Loss of
Loss of her mobility, loss of her dreams.
Yeah.
She talked about how am I gonna go to school, how am I gonna have kids, how am I gonna take care of myself? All of her goals shot down the tube. But
This is the husband, but Martha went back over here for a minute, 'cause we're saying you could do complicated grieving.
Yeah.
Okay, so impaired family dynamic related to. Husband becoming caregiver, right?
he's not used to that. He's gonna have to take care of her, he doesn't know how, he doesn't even know how to turn on the dishwasher, he's never run the wash machine, he doesn't know where anything is, cause he's a guy.
So he's a lady.
Well, not necessarily, he's just used to
I do
taking
the
care of her.
dishwasher.
They're still in the honeymoon part.
That sounds sexy is what you just said. Do you know how to use a dishwasher?
I just wish you push start. You throw a freaking Tide Pod in there.
As long as you don't eat them.
Yeah.
Does everybody get that with, you have your problem, your related to, and your evidence?
That was good.
This is a
Some of these
practice,
Nando list
practice,
diagnoses
practice
sound like
thing.
medical diagnoses.
And it's gonna look different
Neonatal
no matter who
hyperbilirubinemia.
writes it, because you're gonna
Neonatal
put your perspective into
hyperbilirubinemia.
what you see. Remember we talked about cues? Cues are what you see, as opposed to, what was the other part? Cues versus
When do we get our nursing care process?
inference. In other
However,
words, I
we get our
see
lifespan test
tenting in
back.
your skin, I see sunken
I'm just hoping they do it
eyes,
away.
I see dry mouth.
Same.
Those are my cues,
No, grade would be nice.
but what do I infer? They're dehydrated. Okay?
I know we use anxiety. But it's
You're all
not
gonna
anxiety,
catch
it's
different
anxiety.
things.
Once you get
Technically,
And
no,
what you
because
see
it's too broad.
right now might be different than what you see
You might
in
have
30 minutes.
anxiety for
I guess it's
marriage.
more situational.
And when you go in,
I have
she
anxiety
didn't want to talk to you.
completely
She
different.
just got
It's
off the
under the
phone
same
with
umbrella.
somebody and she was pissed. And when you got in there, she was bawling. All different.
Next week we'll try the lecture hall.
But you gotta sit in your groups in the front.
Yeah, come and sit in your groups.
Your PowerPoint should be in your Moodle site. Okay?
Me too.
I just know that
You need to
if
come
we
up
get
with another
great-
one more suggestive.
Yeah, and they get like, when you in church and you all get in your little place and you're just like zoned. And I want that, I want interaction. I want to feel friends. I'm not used to big of a class. I'm not used to people not knowing people's names, so it's hard for me. I mean, for me, I would rather say, hey, blonde girl, instead of, hey, you. Oh, thank you. Yes, a real person, but you're doing the same thing. It should be easier. Actually, June and, Dawn and I are gonna do that probably today and tomorrow, and this week anyway. It's just that we are completely different.
Okay, so do the same thing as this.
Only, just like we just did. And you know what? I don't know the person you're doing.
Okay, perfect. Are you gonna get feedback on what I'm wanting to have candidates for today?
I am gonna,
Yes,
but
she
it's
said we'll
gonna
have-
take me a few days to get through 30.
Have some marks on it.
Yeah, I'll be writing all over that.
Okay, perfect. Can you figure out what I'm doing?
Those are the smart ones. Those are the smart, okay, the goal is the overall what, so for example, person has fear related to changes in their lived status, okay, this person. Okay, what is our